Welcome to the Cancer Research Institute's webinar series, Cancer Immunotherapy and You. Today's date is Friday, May 19th, 2017. The title for today's webinar is Advances in Bladder Cancer Immunotherapy. Before we begin, I'd like to thank our sponsors. This webinar series is made possible with generous support from Bristol-Myers Squibb, Genentech, Regeneron, and Advaxis. My name is Brian Brewer, and I'm Director of Marketing and Communications at the Cancer Research Institute. CRI is a nonprofit organization dedicated to saving more lives by funding research that aims to harness the immune system's power to conquer all types of cancer. This work has contributed to the development of life-saving immunotherapies for a variety of cancer types, and we present this webinar series to patients and caregivers to help them understand what immunotherapy is and how it differs from other treatments, provide information on the latest developments in research and treatment, and connect patients to immunotherapy clinical trials. Now it's my pleasure to welcome today's expert speaker. Dr. Arjun Balar is the director of the Genitourinary Medical Oncology Program and an assistant professor of medicine at the New York University Langone Medical Center. His work primarily focuses on the development of new treatment strategies for patients with prostate, kidney, and bladder cancers. He also leads the NYU Genitourinary Oncology Tumor Registry, which is a multidisciplinary effort to characterize the genomic and molecular makeup of genitourinary tumors to better understand their impact on disease progression and patient response to treatment. Dr. Balar, so much happening in bladder cancer immunotherapy. Thank you for joining us today.
Pleasure to be here. Thanks for having me. So let's get started. So in this first slide, I always like to give a very broad overview of how we manage bladder cancer. In the United States, roughly 75 to 80,000 cases per year in the United States. And it's a disease of older individuals. And the average age is roughly about 70 when patients are diagnosed. And about 80% of our patients are prior or current smokers. And so with that comes a number of medical comorbidities. And these include COPD, cardiovascular diseases such as stroke and coronary artery disease, chronic kidney problems. So our patients who get this cancer are often dealing with a lot of other medical problems as well. So in the first part I'll focus on is the top left-hand side here, where we focus on patients who have what's called non-muscle invasive bladder cancer. These are the tumors that they start in the lining of the cancer. They start in the lining of the bladder, okay, in this area here, and this is where a majority of bladder tumors start. And they can choose to either grow just in the lining, which we call CIS. Tumors can grow out as protrusions into the bladder. We call these TA lesions. They're almost kind of like the polyp of the bladder. And then there are minimally invasive tumors such as T1 tumors that invade into the layer just below the epithelial lining. And these tumors, as you can see here, collectively are what we call non-muscle invasive bladder cancer. They comprise about 70 to 80% of our overall diagnoses and are usually managed by urologists who will do procedures such as resections of the bladder. And this is a type of cancer that often does not progress and becomes more of a lifelong nuisance problem, though. These tumors can recur, but the majority do not invade or progress beyond that. A fraction of these tumors, about 20 to 30% of these cancers can progress to what is called muscle-invasive bladder cancer, and certainly about up to 20% of patients will develop or progress, or at least present with muscle-invasive bladder cancer. This type of cancer is distinct. It is a different type of tumor altogether. It's unfortunately associated with about a 50% risk of spread. What is distinct about this particular type of tumor is that it can invade into the muscle. So this is the T2 tumor, and here it's invading into the muscle. If it invades through the muscle and through the outside, we call those T3 tumors. And if it invades through the muscle, through the outside, and into adjacent organs, such as the prostate, for instance, then we call these T4 tumors. Collectively, these tumors are muscle-invasive bladder cancer, and the treatment for this is radical cystectomy, which is surgical removal of the bladder. It's a fairly aggressive surgery, or chemotherapy and radiation as an alternative. Also, patients can get or should get neoadjuvant or adjuvant chemotherapy with cisplatin. The goal here is cure with this very aggressive treatment approach. However, at the same time, we still understand that even despite this very aggressive treatment approach, up to half of patients will develop what is called metastatic bladder cancer. So this is a cancer that has spread throughout the body. In instances such as this, we consider metastatic bladder cancer to be considered, relatively incurable. We use, up until recently, chemotherapy with drugs such as cisplatin or gemcitabine and carboplatin, so either cisplatin or carboplatin type regimens. And we, for the people who received cisplatin, we extended survival. But for the people who weren't eligible for cisplatin, this in cisplatin-ineligible group, the survival outcomes weren't very good. In fact, they were much shorter because carboplatin is simply not as good as cisplatin. In the second line setting, however, we had other options such as taxane chemotherapy, other single agent chemotherapy such as gemcitabine if you hadn't received it in the first place or in the first line. Vinflunine is a chemotherapy that's reserved only for the European Union, and then pemetrexed. And so chemotherapy here, followed by here, was considered the standard of care until about a year ago, when the first of a group of drugs called PD-1 or PD-L1 antibodies became approved. Even now, this list that I have for you, Atezolizumab and Nivolumab, which were just approved within the last year, this list has now expanded. We actually have a total of 5 drugs now that are approved. Each one is quite similar. They have responses in the rate of 15 to 20% or so. The median survival is somewhere in the range of 8 to 11 months. But I will tell you that what is unique about these treatments is that when cancers shrink, they tend to stay that way. And I'm going to spend the next 15 or so minutes talking about what these treatments are and how we see these treatments impacting the people who are dealing with this dreadful disease. So first, I always start by putting things into context. So what I have here is what we call survival in metastatic bladder cancer. And for those of you who may not be familiar with what are called Kaplan-Meier curves, these are the curves that help describe how patients do with any particular type of treatment. This first plot here is a first-line trial where a large group of patients were randomized to either receive gemcitabine and cisplatin versus another regimen called MVAC. And these were patients who had metastatic bladder cancer, and they received either one of these 2 drugs. What we have is on the bottom is months in terms of time. So time in terms of months, and then on the vertical axis here, the y-axis, is the proportion of patients who are actually alive and dealing with the cancer. So as time progresses, the proportion of patients who are alive, unfortunately, drops. What we see is that with both of these regimens, the dark line and the dotted line, that the survival outcomes were quite similar. However, what it looks like is that long term, about 10% of our patients are alive for many years, and it's possible that these are the patients we may be able to cure with cisplatin chemotherapy. The average survival, though, is roughly in the range of 12 to 15 months. For people who receive this type of treatment here, but then develop progression of their cancer, they are now eligible for second-line chemotherapy, and these are usually chemotherapy drugs given as single agent, not combination like this, but given as single agent, and are usually reserved to help deal with palliation of symptoms. Patients with metastatic bladder cancer are often quite sick. They're dealing with a lot of disease-related symptoms, and our hope is that by administering chemotherapy, we might be able to help alleviate some of those symptoms. And as you can see, unfortunately, the average survival for someone who is dealing with second-line bladder cancer is somewhere in the range of 6 to 8 months. And unfortunately, all patients uniformly die from this disease, which is really a dreadful thing. And this is the context in which some of the new immunotherapy drugs have completely changed how we approach this particular cancer. So what I'm displaying here is the first large phase 2 trial of an immunotherapy drug in metastatic bladder cancer. So this is Atezolizumab, which is a PD-L1 antibody. And the large study was a phase 2 trial called IMvigor210. And in this particular study, they focused on 2 groups of patients. And I'll talk about this particular group called cohort 2. They had 310 patients, all of whom had previously treated metastatic bladder cancer. So these were all in the second-line setting. And what it showed was that about 16% of patients responded to the treatment, so not a huge number, But what we saw is that patients started living for a long time, including the people here. So as you can see, this curve is not going down to zero. In fact, actually, it's starting to level off. And what it shows us is that of the people who respond to this particular type of immunotherapy, the responses can be durable, which means that cancer shrinks and it stays that way, which is what is particularly unique about immunotherapy versus chemotherapy. So since that particular drug was approved by the FDA, a number of other agents have found their way into the clinic. These include Atezolizumab, Nivolumab, Durvalumab, and Avelumab, and as of yesterday, Pembrolizumab. So I will tell you that each one of these drugs targets either PD-1 or PD-L1, and the best way to think about this is think of the immune system as a rephrase that. So the immune system has a bunch of locks on it, and these locks can turn the immune system off. If the right key is placed inside that lock, then that lock can turn off the immune system. Think of PD-1 as the lock and PD-L1 as the key. If we block the lock or the key with either one of these drugs, then we eliminate that off switch on the immune system, and the immune system is allowed to stay awake, or it's reinvigorated and allowed to attack the cancer. So we have two drugs now that target PD-1, or the lock. That's Nivolumab, and what's missing from here is Pembrolizumab. And then we have three drugs that target the key, and that is Durvalumab, Avelumab, and Atezolizumab. And all of those drugs are now approved for use in metastatic bladder cancer. This is a more recent trial that looked at Nivolumab, and what it showed was that about 20% of our patients, almost 19.6% to be precise, of the patients who were enrolled in a phase 2 trial very similar to IMvigor210 had responses to immune therapy. What is also here that I didn't show previously is that, well, one of the major questions that we have in the clinic is to figure out, well, if there are about 20% of patients who respond, is there a way for us to find out ahead of time who those people might be? And there is, and then one of those ways, at least we have a chance to find out who is most likely to respond to the treatment. There is a test called PD-L1 testing. And you may be familiar with this from other webinar series of people talking about immunotherapy, because the PD-L1 staining is something that is ubiquitous across cancer immunotherapy trials involving PD-1 inhibitors. And so what we see here is that higher levels of PD-L1, noted by expression of 5% or greater expression, that the people who had that level, which was 81 people out of the 265, that of those 81 people, 28% of people responded to the treatment. So saying, okay, if you had higher levels of PD-L1, you're more likely to respond to the treatment. On the flip side, though, if you had low levels of PD-L1, that doesn't mean that you won't respond to the treatment. In fact, actually 16% of people who had low PD-L1 responded to the treatment. This is what makes it difficult to use PD-L1 testing in the clinic to help us make treatment decisions. This is the survival curve for that same study. It's very similar to what we saw with Atezolizumab. Notably, the people who had the highest level of PD-L1 here, greater than 1% here, had the best outcomes, which is not surprising. So if you had higher levels of PD-L1, you're more likely to respond to treatment, and therefore you're more likely to live longer from the treatment as well. I'll bring you up to speed with Pembrolizumab, which was just approved yesterday. There was a similar trial, except this is the first phase 3 trial. So what's different about phase 2 trials versus phase 3 is that phase 2 trials, everyone receives the same treatment. In a phase 3 trial, we try to definitively prove if a new treatment, in this case Pembrolizumab, is better than an old treatment, such as chemotherapy. And if you remember from earlier slides, I told you that up until recently, everyone who had second-line metastatic bladder cancer received second-line chemotherapy. And usually it was with a chemotherapy drug like a taxane, such as paclitaxel or docetaxel, or in the European Union, they use vinflunine. And so here what we see is that over time, the people who received the Pembrolizumab did much better. And the people who did receive the chemotherapy didn't do so well. We express this as what's called a hazard ratio, which is basically the risk of death from treatment. Is it better or worse with the treatment? The risk is less, meaning less than 1, with Pembrolizumab, proving, and it's actually less, it's highly statistically significant with a very low p-value, showing that it is definitively showing that pembrolizumab improves survival against chemotherapy in metastatic bladder cancer. This is the first trial ever to really show that in the second-line setting, and this is why we are particularly excited about this class of treatments, because it's something that we have never previously seen before. So now all the trials that I've shown you so far have been in what's called the second-line setting. Now let's focus on the first-line setting, and why I want to set the stage for this particular treatment setting, because there's something unique about bladder cancer that everyone should know about, and that is that even though cisplatin improves survival, it's considered our standard of care, about half of our patients are not able to get cisplatin. Part of that is due to issues such as performance status and kidney problems, and both of those issues make cisplatin particularly toxic to the body. And for those people who are not eligible for cisplatin, we have this designation called Cisplatin-Ineligible, and that's something that's unique to bladder cancer. Unfortunately, for these people, we commonly use drugs like carboplatin, but the outcomes for these folks are unfortunately very poor, and a significant proportion, up to 20%, 20% in one study showed that 20% of people actually never even get treated because of chemotherapy, even single agent, is such a toxicity. But this designation is a little bit unique because it's a function of toxicity, not the actual efficacy or biology of a particular type of treatment. So if we find something that's very promising in the cisplatin-ineligible population, it is potential for broad applicability to all patients. For example here, this is the survival curve for gemcitabine and carboplatin in this patient population. The average survival, if I draw a line from 50% over here, is about 9 or 10 months, and we can see that unfortunately people do not survive for very long with this cancer. So this is a huge area of unmet medical need, and has been my major focus of research over the past several years. So now that sets the stage for us to look at what's called cohort 1. So this was the first group of the Atezolizumab IMvigor210 study, and it looked at 119 patients who were first-line metastatic bladder cancer who were cisplatin ineligible. They were determined to be ineligible for cisplatin on the basis of poor kidney function, hearing loss, neuropathy, or poor performance status. So if a patient had any one of those, they would be considered ineligible for the chemotherapy for cisplatin and therefore eligible for this trial. What's striking is that if you look at the people who were enrolled in this trial, the average age was 73. When we compare it to other bladder cancer trials where the average age is like 65 to 70, we can clearly see that we are now, with this particular type of treatment, the age of the patients that we can offer this treatment to is much greater, and in particular because of the safety, and I'll get to that in a minute. The oldest person we treated on this trial was 92 years young, and 21% of our patients were above the age of 80. So this is really particularly important. Also, about 2/3 of our patients had spread of cancer to areas that weren't just the lymph nodes, and this included areas such as the lungs, the liver, and the bone, and that is in particular a poor prognostic feature, which means patients with this type of cancer spread typically do not do well with treatment. So we were dealing with, in this particular trial, a population of patients who were unfortunately quite frail. Here's what we saw in this particular trial, that of the 119 patients, 23% of patients responded to the treatment. There seemed to be a higher rate of response based on levels of PD-L1 expression. If you remember, that's the protein that we test for, and it has been shown that the higher levels of PD-L1 that you might have, the more likely you are to respond. And here what we see is this is something called a spider plot. And what it shows is that at time 0, okay, every patient starts at time 0, and each one of these lines represents an individual patient. If the line goes down, okay, then that means that their tumor shrank. So on here you can see is that this is the change from baseline. So all of these are negative numbers, which means all of these people here are the people who had responded to the treatment, and it tells us how low did they go, which means how much did their cancer shrink. The purpose of me showing you this is that the people, their cancer shrank, but it stayed that way. And you can see here the time on study in weeks. We're looking at 81 weeks, 90 weeks, 99 weeks. So you're looking at people who are in treatment for up to 2 years, and they're having their cancer shrink and stay that way. And that is what is particularly unique with this class of treatments. When we compare, remember that older plot that I showed you, this is gemcitabine and carboplatin for patients who are cisplatin ineligible. And here is the same survival curve, a survival curve, but for the group of patients who were treated on the Atezolizumab cohort 1 group. And you can tell even from far away that this curve looks a lot better than this one. And in particular, what we see is that there may be some flattening of the curve. And this again is like that phenomenon that we see, that these are the people who are surviving for a very long period of time on the treatment. And we hope that they will continue to survive for a very long time. What we need to know, though, is that what is that going to look like in 5 years from now? We just don't have that much information yet. We simply need time. But when we compare this to what we typically see with gemcitabine and carboplatin, this is very, very encouraging. That being said, though, it's important to note that these are two different clinical trials, so comparing them side by side beyond just the thought exercise is not valid. So we really need comparative trials to tell us for sure if treatment with atezolizumab is definitively better than getting gemcitabine and carboplatin, which is the older treatment that we used to give patients. So we fast forward to another particular study that we did. We looked at pembrolizumab in the exact same group of patients. So this was the study called KEYNOTE 52. Pembrolizumab, as I mentioned before, is a PD-1 antibody, again focusing on cisplatin-ineligible patients with advanced bladder cancer. We saw 24% of patients respond, which is quite similar to what we saw with atezolizumab, again suggesting that these drugs are quite similar, and also that there was a higher level of response according to PD-L1 expression. Now, the drug company that supports pembrolizumab used a PD-L1 scoring system that's a little bit different from atezolizumab. They use something called combined positive score, which is not so important, but their scoring method was different, but the message is the same, which is that 37% of people, if you had higher levels of PD-L1, then you responded to treatment. But at the same time, if you had very low levels of PD-L1, it didn't mean that you didn't respond to treatment. You just had a lower likelihood of responding. So then that was the first 100 patients that we enrolled into this trial. Now this is the entire study population. This is 370 patients. And what we see here is that if you can read the fine print, it's 24% of patients, again, out of the 370, responded to the treatment, and that the patients who had the highest level of PD-L1 positivity, which means a score of 10% or greater, 39% of the patients responded. Now there's something unique here, that is the patients who had greater than 4 months of follow-up. These are because the average follow-up time for the people on this trial was only 5 months. We focused on the group of people who had enough time on study, whether they progressed or not, to have had at least 4 months of follow-up or more. When the analysis was limited to those people, then the response rate was 27% and 48% for people who had high levels of PD-L1 expression. This is particularly important because what we have learned is that sometimes as we continue to treat people, patients who have initially stable cancer can develop shrinkage of cancer. And that's what we mean when we say new partial responses and sometimes new complete responses show up by giving patients the opportunity to access treatment for a longer period of time. So why does this all happen, right? One major reason why this happens is that bladder cancer, as you can see here, has a very high mutational burden. So what you see here across the bottom is all of the individual types of cancer. Well, I'd say not all, but many of the different types of cancers that we have in humans. We have melanoma over here, we have different types of lung cancer, we even have kidney cancer here, prostate cancer, pancreas cancer, myeloma, so all different types, and all the way over here, thyroid cancer and leukemia. And vertically, what we see is the amount of mutations, genetic mutations in the cancer. Bladder cancer is one of the highest. And that is one of the reasons why we believe that immunotherapy works, is because that the more mutations there are, the more foreign proteins that are made because of those mutations, and those foreign proteins your body's immune system can recognize as being bad or foreign. We look to see if that mutation burden, or what the level of mutations, helped predict who would likely be to respond to the treatment. And that's what we found, is that when we looked at the atezolizumab IMvigor210 study, people who were treated in the second-line group, called cohort 2, and patients who were treated in the first-line group, called cohort 1, the higher levels of mutation, here where it was broken down into quartiles, the highest level of mutations in quartile 4, here and here, had the best survival. These are the people who lived the longest. So even though within bladder cancer, there are people who have low mutations, high mutations, I mean, overall, on average, they have the highest level of mutations. The people who had the highest here responded to the treatment the best. Then there was another interest. Is there a way for us to know if, while someone is on treatment, can we predict if they're going to benefit? And the group, colleagues at Memorial Sloan Kettering, tried to answer that question by sampling the blood of people who were receiving treatment on this IMvigor210 study. And just the quick highline message here is that what they looked at is that group of people. There was a group of people who responded, and they took one person who was quite a good example of that, and then they looked at the people who did not respond to treatment and looked at a good example of that. And what these individual dots show are the presence of T cells in the peripheral blood that expanded with treatment, which means they looked at the blood at baseline. So they collected blood before patients started treatment, and then they collected blood after the patient started treatment. And what they found is that the people who had an expansion of T cells in the blood with treatment, and that's what these orange dots are, they are the ones who were most likely to respond. If they did not expand any of the T cells, and this particular person, he only expanded one of the T cells right here, those are the people who were least likely to respond. And as you can see, he has overall fewer T cells than this particular person. So what that tells us is that on treatment, that's one way we can see if someone is destined to respond to treatment and early on. So this was blood that was collected at 3 weeks, right here, 3 weeks after starting treatment. And this is something that will need to be tested in larger studies to see if we can reproduce these findings. Okay, so the last couple of slides here, where is the future headed, right? So if I told you that 15 to 20% or even 24% of people respond to this immune therapy, yeah, that's all well and good, but obviously where is the future headed? So we need to work on improving our immunotherapy so that we can increase the proportion of patients with bladder cancers who respond to this class of treatments. The mechanisms that the cancer protects itself with are varied. And so with that, we must attack it with any number of different approaches, and they will be highly individualized. So we may combine immune checkpoint inhibitors such as Pembrolizumab, Nivolumab, Durvalumab, any one of those drugs that I just mentioned to you. We can combine them with other immune checkpoint inhibitors, chemotherapy drugs, which may, in certain instances, improve the immune system response, radiation treatment, anti-angiogenic therapy, which means blocking the way blood vessels grow around cancer, and then also targeted therapies, which are specific to genetic mutations. Any number of these different approaches might lead us to improve responses to immunotherapy. Okay, here are some ongoing studies that we're working on, and this is a very high-level view. There are so many different trials in bladder cancer going on right now. It's almost impossible to keep up. It's really an exciting time in terms of drugs that we will be able to offer our patients. I will quickly mention a couple of studies. Tremelimumab, okay, here is a CTLA-4 antibody, and that is a different type of immune checkpoint compared to PD-1 or PD-L1. And this type of combination is a standard of care in melanoma, and we hope to soon find out if it is potentially a standard of care in bladder cancer. There are a number of trials, these two trials addressing it, and we hope that by adding a CTLA-4 antibody, such as tremelimumab, to a PD-L1 antibody, such as durvalumab, that we might increase the proportion of patients who respond to immunotherapy. A similar approach was done by the makers of nivolumab and ipilimumab, and what they found was that it was a subgroup of patients who had a 38% response rate to nivolumab and ipilimumab. So we might be seeing that using this combination together might improve responses to bladder cancer. My particular area of interest is also to look at angiogenesis inhibitors, in this particular case a VEGF antibody. VEGF stands for vascular endothelial growth factor, and combine that with a PD-L1 antibody, and we're doing a phase 2 trial of that. And also what I'm looking at is using traditional chemotherapy and radiation, which has been shown to improve immune responses, along with a PD-1 antibody, and use that as an alternative to surgery in patients who have muscle-invasive bladder cancer. And this is a trial that we're leading here. So a lot of different ways that we can use immunotherapy in combination with chemotherapy, radiation, other immune checkpoints, and there's so many other trials that are ongoing right now to try to help improve outcomes for patients who have muscle-invasive and advanced bladder cancer. So where is the future of bladder cancer immunotherapy? I think it's a very, very bright future. I think we're changing the way patients are being treated, and I would say easily that the advent of immune checkpoint inhibitors are the most important clinical advancement in bladder cancer in nearly 3 decades. What we have observed is active treatment with durable responses, which means cancer shrinks and it tends to stay that way. Treatment appears to be well tolerated. Most patients tolerate treatment exceptionally well, and the side effects are manageable. That being said, though, toxicity management is extremely important, but they have transformed bladder cancer therapy. Now our focus turns toward enhancing the effectiveness of immunotherapy through combinations. We need to test the effectiveness of immunotherapy earlier in the course of treatment, and we're starting to do that now with the approval of both Atezolizumab and Pembrolizumab as first-line treatment in Cisplatin-Ineligible bladder cancer. Both of those approvals happened within the last 2 weeks. And then also we want to test them in earlier stages of the disease, which means can we use immune therapies, let's say for patients who have muscle-invasive bladder cancer at first diagnosis? And also, can we use it in patients who have non-muscle invasive bladder cancer to prevent them from progressing to muscle invasive cancer or from needing surgery to remove their bladder? So many different ways that we can test immune therapies and combinations. We will be doing that over the next 5 to 10 years in a very, very active area of research. So with that, I'm done.
All right. Well, thank you so much for that, Dr. Balar. Very exciting for bladder cancer patients. I was really struck by your closing statement there that this is the greatest advance to happen in the treatment of these patients in 30 years. So it's always exciting to see progress is being made. More patients are being helped, especially now with this new class of treatments called immunotherapy. But as you said, there's a lot more that still needs to happen so that more patients benefit. And very, very interesting too that Pembrolizumab approval was for that first-line treatment. Part of the approval was first-line treatment for the Cisplatin-ineligible patients. So I was glad that you mentioned that because that's a whole population of patients who didn't have perhaps the other standard options, treatment options. So it's wonderful. So just a few questions for you before we wrap up. You mentioned at the end that these treatments are well tolerated, and I was wondering if you could say a little bit more about what are the types of side effects that you might see when receiving treatment for this. Is it different from patients who receive the same sort of drugs in other types of cancers, or are they very similar?
So that's a really great question. So obviously if someone says treatment is well tolerated, that's obviously with the caveat that they're not completely benign. So when we think of chemotherapy toxicities in comparison, yes, they are better tolerated. That being said, though, about 15 to 16% of patients will develop a moderate to severe side effect from the treatment. And about 2/3 will develop at least some sort of side effect. And that means 1/3 may not develop any. So that type of ratio is actually much higher, unfortunately, with chemotherapy. So overall, less frequent. But the side effects are unique. So what I tell my patients is that immunotherapy, think of it as it's boosting your body's immune system, and as it does so, there's some innocent bystanders along the way, which means normal healthy tissues can be the kind of unwitting target of the immune system. And most commonly we see it such as the lung, and it can manifest as inflammation in the lungs, such as shortness of breath or cough. And it can also irritate your GI tract, and it can develop diarrhea or blood in the stool sometimes. Other common side effects include irritation of the endocrine organs, which means the hormone-producing organs of the body, such as the thyroid gland most commonly, but rarely the pancreas, the adrenal gland, pituitary gland. And when those things happen, the hormone needs to be replaced, which means that if, let's say, the thyroid function goes down, now somebody needs to be on thyroid replacement. The other side effects, however, such as, let's say, diarrhea, shortness of breath, and another less common one called inflammation of the liver or hepatitis, each one of those things needs to be treated with steroids and aggressively. And it's really important that when patients get treated with this, that they're counseled on the development of these side effects, that they know when to reach to their physician when they develop any of these things so they can be managed appropriately.
You mentioned that it was important to note that in one of the trials you showed us a significant number of patients in the study cohort were above the age of 80, and I wondered if you could say a little bit more about what it means for older patients. Is it a concern for them to consider treatment with immunotherapy given their age, or is there really not a difference? I mean, just one example, Jimmy Carter was treated with an immunotherapy at a very advanced age, and he did well. But is that the case for all elderly patients?
That's an exceptional question, and I think that's what I was trying to touch on, is that because the side effects are less frequent and less severe with immunotherapy, the percentage of patients who can receive this type of treatment, including older individuals, is much greater. So before, cisplatin chemotherapy was definitely a significant concern, especially even in my practice, that especially folks who are above the age of 80, we proceeded with caution. And some of our patients above the age of 85, I would be very concerned about the side effects of any chemotherapy. With immunotherapy, there are fewer concerns, and they do not appear to be age dependent. And when we looked at the individual groups of patients in terms of side effects and outcomes, when we broke them down between patients who were, let's say, 60 to 70 years old, 70 to 80 years old, and 80 to 90 years old, the rate of side effects were actually not significantly different between the groups. So this is potentially a treatment option that we can offer patients who otherwise would never receive chemotherapy.
That's excellent. I imagine older patients make up probably the vast majority of patients diagnosed with that type of bladder cancer. So that is good news. Let's talk about the PD-L1 as a predictor, an imperfect predictor, I think you said, about the outcome of patients and the likelihood of a patient responding to treatment. So it looks like from the data, there's, those with high levels of the PD-L1 tend to do better, or more of those patients tend to respond than patients with lower levels. But doesn't mean you won't respond, as you made very clear. But do doctors have to test for PD-L1 expression when administering these drugs? Is that an important standard? Is that something special that a patient needs to ask to have done?
That's a great question. Because of what what I've kind of mentioned about how it's an imperfect biomarker, each one of these drugs has a complementary diagnostic attached to it, which means that you can order the PD-L1 test, but it is not required to administer the medication. And that is in large part because we do observe people who have even low levels of PD-L1 respond to the treatment. So for instance, when we looked at the Atezolizumab study or the Nivolumab study, patients who had low levels of PD-L1 still responded to the treatment. And that response rate was somewhere in the range of 10 to 15% of people responded, even if they had low levels of PD-L1. What we know is that traditional chemotherapy actually has a response rate of 10 to 15% in all comers, which means that even if the low PD-L1 group is in that range, then it really argues for not really testing routinely. That being said, though, as we move these drugs into the first line setting where some patients may be candidates for chemotherapy, then we can envision potentially that PD-L1 testing might have some clinical use. So for instance, someone who is having a lot of symptoms from their cancer but has a low PD-L1 level on their tumor, some patients might need chemotherapy first to get their cancer under control and then receive immunotherapy. But that's something that still we need to work out in trials.
Very important to remember that there often is no one single magic bullet that can help a patient, and sometimes it does involve combinations of current treatments like surgery and chemotherapy along with immunotherapy, targeted therapies, and the like. So very, very important point. And it's also important to point out that, as you did, that there are so many clinical trials that are testing these combinations, and that's an intense area of study. At the very beginning, you mentioned that I think the number you gave was about 80% of patients with bladder cancer have a history of smoking.
Yes.
Can you say a little bit more about that? Because I think smoking, I think lungs, I don't think bladder. So why is that?
Yeah, so that's a great question. I can't tell you how often I've had conversations with my patients who had no idea that bladder cancer was at all related to their history of smoking. And that's because, just like you mentioned, most people think of head and neck cancer and lung cancer and even esophageal cancer because that's where they think the tobacco smoke first goes, and that's true. But the thing is that tobacco smoke and the carcinogens in tobacco smoke also enter the bloodstream. And then when that happens, the blood is filtered throughout the body, goes to the kidney, and where the kidneys filter it, it ends up in the urine. And then where does the urine go? It sits inside the bladder. So if there are any carcinogens in smoke, they eventually get exposed to the bladder. And chronically, over many years, there can be genetic changes inside the bladder related to that carcinogen that can develop bladder cancer. So some of my patients will have, were heavy smokers in their younger years, quit 20 years ago, and then they get diagnosed with bladder cancer. And we know that that smoking history is probably what caused it.
So the role of carcinogens here in causing mutations in the bladder tissue, which causes or results in cancer, you touched on kind of high levels of mutation as another indicator of a way to potentially see how likely a patient is to respond, with the idea being that the more mutations there are, the more visible that cancer is to the immune system. I know that some studies have shown that other cigarette-related cancers like lung cancer, the patients who develop lung cancer as a result of smoking tend to be more responsive to immunotherapy than patients whose lung cancers arise from other ways. Do you see the same thing with patients with bladder cancer who have a smoking history? Do they tend to do better than patients who didn't have a smoking history?
So yes and no, partly because smoking is not the only carcinogen that leads to bladder cancer. The other 20% of patients also are exposed to other carcinogens. So that's where it's difficult to say. So the other carcinogens include people who work in the chemical and dye industries who are exposed to certain chemicals and solvents that are based in aromatic amines, benzenes, aniline dyes. So those are also carcinogens. So since the majority of people who develop bladder cancer are carcinogen-based, it's hard to tease that out. But nonetheless, you're absolutely correct. In general, carcinogen-based tumors tend to have the highest mutational burdens. And then on top of that, they're the ones who are most likely to develop what are called tumor neoantigens, which is what the immune system recognizes.
Are there any factors that would commonly, that you may commonly see that would make a patient ineligible for immunotherapy or otherwise not a good option for them?
Right, so that's a great question. So beyond the first description that I gave of a patient who has a lot of, a high disease burden, which means that the volume of cancer is very high, what we have learned is that the patients who were least likely to respond to immunotherapy were the ones who had low PD-L1 expressions and also the people who had high volume of cancer, which means the total sum of the tumors and the sizes was very high. So there may be a patient, let's say, who is up front, who is presenting with metastatic bladder cancer, who has a high volume disease burden, has a low PD-L1. That may be somebody I might treat with chemotherapy first. Now, the other part of it is that, is there anybody who just should not be treated with immunotherapy at all? And I think that's a much more challenging question to ask. So from a safety perspective, which is the main issue, right, is that the patients who were not included in these clinical trials are the patients who have a history of an autoimmune disorder. This includes disorders such as lupus, rheumatoid arthritis, and Crohn's disease. And these type of conditions are described, basically they're conditions where the immune system is already overactive and it's attacking healthy organs already. So if you give a PD-1 or PD-L1 antibody to someone like that, they could suffer from a significant worsening of that particular condition. And so those people were excluded from the trials. But as you can imagine, in a practical setting, when a patient is facing a potentially life-threatening condition such as stage 4 bladder cancer, but then also has a history of an autoimmune condition, that is something that should be a shared decision between the care provider and the patient about them wanting to take the risk of receiving immunotherapy.
And my last question before we wrap up is, NYU Langone Medical Center is one of the country's, best treatment centers for receiving cutting-edge therapies like immunotherapy. How can you just say a little bit about how treatment decisions are made there at NYU, and then how does that compare, to the best of your knowledge, to community oncologists, and what should patients in those settings do if they don't have access to these really high-powered research centers?
That's a great question. And one of the things is that what we are learning every day, and that we've actually always known, is that cancer is complicated. And when patients are presenting with a cancer diagnosis, not only are they overwhelmed, but they're also overwhelmed with how to make treatment decisions. And as we learn about the complexity of cancer, sometimes you need a surgeon, sometimes you need a radiation doctor, sometimes you need a medical oncologist, sometimes you need all three. And often being able to navigate between all three requires a multidisciplinary approach, which means that you have a team of people who work closely together. Let's say in our institution, we have a team of surgeons, so urologic oncologists are specialized in urologic surgery. We have a radiation oncology group that is highly specialized within bladder, kidney, and prostate cancer. And then medical oncologists such as myself and other members of our team who are highly specialized within their disease states. And what we do is we work extremely close together. So when a patient presents, we have tumor boards, we have access to cutting-edge molecular analysis and pathologists, and this multidisciplinary team delivers the best precision care, so the highly individualized care for that individual patient. But I agree with you, it is a challenge when on the community if you don't have access to it. So what I always suggest is that try to find opportunities to find a second opinion, reach out to your physician and see if they can reach out to a specialist in the area or within the region. Going to, for instance, for bladder cancer, a great resource is the Bladder Cancer Advocacy Network, which is a great foundation that supports patient advocacy, policy, and then research, which means access to information about clinical trials. So we lead at NYU, we pride ourselves that we have the most cutting-edge clinical trials available, but sometimes you need to find an online source to help you find where the nearest one might be. And sometimes that could be right around the corner, and you just need to do a little bit of research and find it.
All right, well, thank you so much. That's all the time we have today. This was great, and like we said at the beginning, this has been an exciting time for patients with bladder cancer in terms of new treatment options becoming available to them and getting approved in the United States, at least. With that, I'd like to wrap up. I'd like to thank our sponsors one more time, Bristol-Myers Squibb, Genentech, Regeneron, and Advaxis Immunotherapies. If you'd like to learn more about cancer immunotherapy treatment for bladder cancer, we host on our website at cancerresearch.org/bladder-cancer information on immunotherapy for bladder cancer. And on that site, you can also be connected to clinical trials testing immunotherapies in bladder cancer. You can speak to a clinical trial navigator who can help connect you with a trial. And we have other resources for patients and caregivers. And I'll also point out, since it's on our website, if you want to get a little deeper into the science, that information is also available, but we really strive to produce information for patients so that it's understandable to you and your loved ones. If you liked this webinar, I strongly recommend that you check out some of our others. Not only do we do webinars about immunotherapy specific to different types of cancer, like today's webinar, we also offer several general immunotherapy webinars. If you'd like to go a little deeper on understanding what checkpoint blockade is, one of the important immunological mechanisms that Dr. Balar described, then we have webinars for that, so strongly encourage you to check that out. Dr. Balar, thank you again so much, and thank all of you for watching today's webinar. Goodbye.
Thanks.